I'm not sure if you know Mareka, but I met her briefly and thought about having this talk a few years ago. Oh, okay. Thanks, Million. It was at the UHC event in Pretoria I think it was 2 years ago, Mareka, that I met you. And you were sharing about the incredible work you do, the activism you do around one of the most disadvantaged and vulnerable populations is disabled peoples living in rural environments, and the program of work, the multidisciplinary program of work that you've done. So Mareka is a physio by training, but is also subsequently trained in public health and health economics, and lives and works in northern KZN in Manguzi. And I think you'll be able to tell us a lot more about everything you're doing. And I'm just delighted that you can be here. This is such a critically important topic. And I'm going to hand over and see if Mareka is there. Yeah.
Hello. Thank you, Tamara. Yeah,
Great.
good afternoon, everyone. It's good to be here. Thank you for showing an interest in a topic quite close to my heart. Should I start by sharing screen?
Does your camera work where you are? It would be nice to see you if possible.
It might. I'm actually in Joburg, and it should be better. But with the water outages and everything else, I'm like, Joburg, seriously, you need rural allowance.
Yeah, I know. They could learn a thing or two from you up north. I think. Well, let's see. The camera's working, the sound is working, but you'll just forgive me if I interrupt you. If there's any trouble with sound or picture, I'll let you know. Just forgive me in advance. Okay. And just a reminder to people you can drop your hands for now. So just do lower your hands. Otherwise, we think you'll want to speak. Unless someone has something specific. Over to you, Mareka. Thanks a million. Oh, and you can share your screen as well if you have slides.
Okay. All right. Can you see my screen?
Coming through.
Yeah, I might switch my camera off. This internet is not the best. Yeah?
Okay.
All right. Cool.
Perfect.
So, all right. Good afternoon, and thank you all for joining the first lecture of the 2026 series, and also for giving me the opportunity to share what we've learned in Manguzi over the past couple of years. I've been there for 24. It's been a while. I've been lucky. So for those of you who don't know Manguzi, it's a deep rural area in northern KZN. It's nestled on the border of Mozambique. It has a scattered population of something over 120,000, and it has a medium-sized district hospital. It's got 13 residential clinics, and the rehab team is pretty large by district hospital standards. We've got 4 physios, 4 OTs, 1 speech therapist, 3 audiologists, and 3 support staff. So the department also works closely with 2 wheelchair repairers who are paid at the moment through a service level agreement between Department of Health and DPSA, and also with a local peer support DPO, which is Disabled People's Organization, who provides psychosocial support services to patients and families with cerebral palsy or spinal cord injuries. I'm hoping that my slides transition. There we go. So a talk on universal health coverage would not be complete without a slide on the UHC cube. It is a standing joke, apparently, in economics units. The NHI itself is a financing strategy aimed at progressively delivering a package of health services to the wider population. The aim is obviously to enable all who are covered to access the healthcare they need, when they need it, at a cost that will not impoverish them. But there is no one-size-fits-all for service delivery strategy, geographically, as well as across subgroups of the population. If the way that we structure and deliver services means that end users have to pay a large proportion of their meager income to get to the service, they are unlikely to use it unless it is an emergency. If the health professionals delivering the service are poorly trained, have an ableist attitude, or are unrelatable, then it's pretty unlikely that many people will use their services, and definitely not on a routine basis. So, if we want to get the best health outcomes, but we fail to acknowledge the impact of the social determinants of health, we'll never get the outcomes we seek. And so, sometimes smaller subgroups of the population who have typically been overlooked for ages need extra attention. This is what we call vertical equity. The talk is on this. So although people with disabilities are by no means a homogeneous group, there are a few shared issues that need to be highlighted. There's a wealth of literature out there on the barriers of accessing services. Unfortunately, this seems to be confined to paper rather than pragmatically integrated into service design and delivery packages. We don't really need too much more on what are the problems around accessing services. What we do need is how to make it better. There's also not a wealth of literature on routinely monitoring access to care for people with disabilities in Southern Africa. And if it's not measured and monitored, it simply won't happen, and the additional resources required to achieve this vertical equity simply won't be allocated. So this is a mammoth but very urgent issue, and I'm throwing this back at the public health, disability researchers, and health economists in this webinar. At the very minimum, we realize that people with disabilities pay exponentially more for public transport than their non-disabled peers. But how many papers are there out there describing how much this is? Patients may pay for 1 or 2 trips, but as soon as it's going to impoverish them beyond a certain threshold, they're going to stop arriving, definitely for their rehab appointments, and definitely if this means multiple routine visits to multiple health professionals over a long period of time. So often we design the services according to what's convenient for us as healthcare professionals to provide, or we base recommendations on guidelines that were applicable to more affluent populations. And then we are disappointed because the small amount of resources and time we have thrown at this problem are then not yielding the results that we actually wanted. Because I'm here to entertain you for an hour, I'm now just going to tell you a story. Okay, so listen up, children. Baby X had a traumatic birth and was admitted to nursery for 2 weeks. He was seen daily by the rehab team and his mother received counseling. They were both admitted into the rehab department's high-risk baby program, which provides follow-up rehab screening services every 3 months at the mother's closest primary healthcare clinic to monitor development and identify any potential problems early. Baby X and his mom were eventually discharged from hospital, but failed to arrive at their 3-month follow-up clinic date. This triggered a request for the community health workers in his area to trace him and his mother and try and bring them back into care. The community health workers struggled to locate them. 6 months passed, during which repeated calls were made to try and trace this pair. Eventually, thanks to a community health worker, they arrived at their closest primary healthcare clinic on the OT day. After assessing the child, the OT counseled the mom as she suspected that this child had cerebral palsy. She referred them to the district hospital's weekly multidisciplinary pediatric clinic for further workup, only 90 kilometers away. They did not arrive for this appointment. Another 2 months passed, after which they arrived at the same primary healthcare clinic to see the OT again. At this point, it was decided that a working diagnosis of CP was going to have to be made and that the child needed, at bare minimum, specialized seating. The OT took measurements, placed the child on a posture support buggy waitlist, and fitted him into a customized APT box seat, which was secured into a basic folding frame wheelchair at the next clinic. And after that, we never saw them again. And in 2018, this would have been the end of the story. We provided rehab services at district hospital level and at clinic level. And although our high-risk baby program utilized active surveillance, where a missed appointment triggers a track and trace response, our CP program did not. The onus remained on the moms to bring their kids back to clinic for care. So why should this story and this presentation matter to you? So I imagine many of us here today work in the public sector, with its emphasis on expanding coverage and retention in care, within an increasingly austere financial environment. And with NHI remaining on the agenda, perhaps you're thinking about contracting. Imagine you were being paid under capitation, where you got a lump sum annually to provide a defined package of care to this defined CP population. So imagine your profit was determined not only through addressing efficiency and skills mix, but also through pay for performance, where a bonus is paid if certain coverage, output, and outcome targets are met. A conventional approach to service delivery and the existing routine health information that we usually collect will not get you far here. Many of you may also be involved in the rising medical legal claims. Although these have undoubtedly brought CP and disability to the forefront for the first time, our inputs, service designs, and decisions made now have the potential to shape services well beyond the few who have successfully claimed and into the future. So perhaps you're involved at a health systems and financing level. As a health economist, academic, and public health specialist or program manager, joining this webinar because you have an interest in expanding access to quality care, healthcare for all in South Africa. Have you ever wondered about unmeasured unmet need, subgroup analysis, the hidden millions, those who are not captured as routine statistics and methodologies that largely ignore the very challenges that the subgroup experiences in accessing and remaining in comprehensive care? Are you still under the impression that a community health worker can solve all health problems at the coalface? This story and this presentation is, of course, set within the contexts of the public sector, with its program silos, its high staff turnover, its fragmented health records, lack of end-user involvement in service design and delivery, and calendars of every conceivable meeting under the sun except a case management one, which, come to think of it, also describes a lot of the private sector as well. For those of you unfamiliar with CP, wheelchairs, and seating schedules, I'm going to try and simplify a few concepts before I continue. So for wheelchairs and seating services, I'm going to use two simple analogies. Firstly, like you would service your car at routine intervals and repair it in between as needed, wheelchairs are no different. The more routinely you service them, the longer they last. Important in a rural low-resource setting. Secondly, if any of you have children of your own, how often do you have to buy them new clothes because they've outgrown their old ones? So like clothing, wheelchair seating also needs reviewing and adjusting every 6 months. If you're classified as having intermediate or advanced seating needs, you'll need a therapist who has completed additional training in this. This includes all children, anyone with a progressive condition, and anyone with postural asymmetries. If your child has outgrown their wheelchair settings, their environment or needs have changed, or their bodies have changed, and no adjustments are made, the chair is going to be discarded, and it's normally used as the clothes horse. Essentially, it becomes wasteful expenditure. The next concept you have to grasp is the critical one of getting to a clinic or to a hospital with or without your device. If you have a child who's unable to walk, then you're going to need to carry them. This normally works until the kid becomes too heavy, after which we never see them at an institution again. If you want or need to bring the wheelchair or buggy with you, which is necessary from a clinical intervention perspective, but also a basic human right, this will incur additional taxi fare or the hiring of a private car from the community. So this adds anything between 100 to 1,200 Rand to the patient's bill for a single round trip to clinic or hospital, depending on where they live. So it's no wonder we never see these devices or older children and adults with severe disabilities again, unless we go to the homesteads ourselves. You book 6 clients for wheelchair review seating clinic at a hospital, only 2 arrive. It's a waste of a professional's time and a poorer outcome for those who could not afford to arrive. And in the end, they abandon their device, essentially. It's wasteful expenditure again. But probably the most important one, about which there are realms of papers written, is the difference between the medical model and the social model of disability. And this really requires a fundamental shift in how we're thinking about healthcare service delivery. In 2018, we provided group and individual rehab for patients with CP at hospital and primary healthcare clinic levels. Primary access to CP services was via the well-run and well-monitored high-risk baby program. Rehab services were well integrated into the existing primary healthcare structures, although no home visits were provided for kids with CP. Although a rudimentary CP database had been kept over the years and had 72 names on it, some with contact details and clinical information, only 36 children regularly attended rehab. Posture support devices were provided to kids on the waiting list and fitted by an appropriately trained seating specialist. However, despite providing these services down to clinic level, attendance was haphazard, and children only received an average of 1 rehab session every 6 months. And once a wheelchair or a buggy was issued, although you saw the child again, you never saw the buggy again, as the moms never brought them to clinic due to the cost of transport. So we had a 0% seating review rate for the 0 to 5s. And then COVID hit with its hard and prolonged lockdown. Reducing our services to inpatient rehab for 3 weeks, it became evident that in order to prevent further disaster, we needed to shift our services for the most vulnerable clients to homestead level. This was no mean feat, especially as databases for separate services were housed on separate laptops and didn't speak to each other. As we amalgamated them, the duplications, the previous missed opportunities, and the inefficiencies became apparent very quickly. By the time we cleaned it up and added a risk rating to each client, we had over 400 names that needed urgent home visits. We needed another plan, and considering that each client required multiple professions and services at different frequencies of follow-up, we needed a better approach to data management. We set about redesigning our own rehab health records electronically, pulling data from the client's profile and clinical entries into program dashboards linked to geographical clinic areas. These clinic dashboards gave our clinic teams real-time feedback on who was on track and who was overdue for follow-up care for services such as CP, wheelchair seating reviews, and home-based care. It also allowed different rehab professions to access each other's notes regardless of where they were, whether they were at homestead, clinic, or hospital level, and provided clinical teams with program performance data. It allowed managers to access all the clinical notes for auditing purposes, apply a range of custom filters to answer questions around service delivery, and to access a wide variety of output data. We also set about strengthening our local DPO and training parent facilitators, as we needed more hands and ears at community level to act as early warning systems and assist in reinforcing rehab programs. Because this was COVID and there was extreme food insecurity, we also collected household data and the cost of a single round trip to clinic and hospital to enable us to raise funds for food parcels and advocate for a second outreach vehicle. So the results were pretty astronomical. Within a year, the new parent facilitators had traced and brought back into the system the majority of the 72 CPs on our original list. And within 2.5 years, we had 166 on our list. The sheer level of unmet need was astounding. Seating coverage and review rates rocketed because we were doing them at home. By shifting services to homestead level and adding a parent facilitator to the team, psychosocial issues came to the fore, issues that affect follow-up rates and adherence to rehab programs. The real issues at home affected the goals that had previously been set at clinic or hospital and the approaches going forward. The parent facilitator soon built up a strong network, with parents readily phoning them with the smallest concerns that sometimes required our intervention as a rehab team and sometimes could be managed by the parent facilitator in the community. So why did this work? Well, essentially, we had addressed many of the aspects around affordability, acceptability, and accessibility, and we shifted the onus of coordinating and remaining in rehab and the cost of doing so from the patient to the rehab team. So if you're still unconvinced from this data on decentralization, here's our attempt to calculate catastrophic health expenditure using social grant and transport cost data collected during COVID outreach for 82 families with a child or adult with CP. Obviously, a lot of assumptions had to be made, and this is merely a proof of concept, but in continuing to offer rehab services at hospital and clinic level, 18% of households surveyed would have been pushed into catastrophic health spending within 8 months of adhering to rehab follow-up dates. If we only ran a hospital-based service, 49% of these households would have been pushed into catastrophic health spending. So do we really need more convincing? I'm not from the same culture, language, or socioeconomic group as the clients I'm providing services for. I don't even have a child. Some of my therapists are and have children, but even then, none of us have a child with a disability. We may have the education and the training, although the level of undergrad training in CP and seating is woefully inadequate, but we don't have the authenticity and we're less relatable. Parent facilitators also hold therapists to account and add a layer of humanity and sustainability to the system, especially in a system whose workforce is highly mobile and very junior. They add accessibility, acceptability, and affordability to the service and really are an irreplaceable adjunct to the traditional rehab services. So if you're wondering more about these parent facilitators, Malamalele Onwards, NPO, offers an excellent and thoroughly affordable 1-week-long standardized parent facilitator training course for those who want to know more. They have a website. Gillian Salugi has also authored a chapter in the SA Health Review on the development of this course content. So most program managers underestimate the level of complexity involved in managing a proactive multidisciplinary rehab service across multiple service delivery areas. A single patient can require different services at different service intervals by different rehab professionals at different levels of care. All of this needs coordination, and some of this scheduling can indeed be automated. So we want to aim for a proactive system rather than a system that waits for the disaster to eventually get admitted into a hospital ward for an extended costly stay. We want the devices we spend so much money on to be used appropriately and beneficially for as long as we can get them to last for. We want to avoid missed opportunities, duplicated efforts, and lost to follow-up cases. But we overestimate health professionals' data literacy and in the incorporation of it into planning and managing day-to-day care. A lot of work is still needed in this area, and the data is really only as good as the people that enter it, and the service is really only as good as the data that's used to inform it. But although we were patting ourselves on the back and telling ourselves what a great rehab results these were, CP is more than just access to rehab. Unfortunately, convincing our other colleagues to join us on home visits was not such an easy task. So sitting down with them, we developed a screening tool together that the rehab therapists and parent facilitators could implement at home visits. It covered medical, dental, nutritional, socioeconomic, audio, and assisted device needs. Some basic in-service training was required, and the screening form was added to our electronic health record to the patient's profile, and a dashboard showing real-time data on the proportion of CPs screened and the results was developed. 156 adults and kids with CP were finally screened over a 6-month period by the rehab team. The results were a shocker, and thankfully bad enough to instantly galvanize our broader team of healthcare professionals. I'm not going to read the results out. They are up on the screen. They're pretty shocking. But there was still hesitancy around home visits. Doctors took a lot of convincing to even walk outside the gate and to see the 9 kids in the disability center for chronic prescriptions. Dental willingly extracted teeth in theatre if the patient arrived. Dietetics mobilized their nutritional advisors at clinic level to trace the severe malnutritions and bring them into clinic for a baseline dietetics consult. Thereafter, parents had to follow up monthly at clinic for supplements, but only needed to bring the child in physically every 3rd month for a review. Speech and audiology came out on home visits with me and did baseline assessments. Hallelujah. But 6 months later, that was all that had been done. The follow-up data was collated and presented back to the broader team. Of the 41 malnutrition cases into the OSP program by the dietitians, 15 instantly defaulted. We know why. Of the 24 kids referred for extractions, only 6 arrived. We know why. But it's not just the cost to the client or the social support issues at home. Understanding data and using data to guide service delivery is not something inherent in health professionals. Of the 41 clients referred for wax impaction or fungal infections by the audio prior to being able to screen their hearing, none were followed up. Similar behavior was observed in speech. Until we foster a culture of M&E amongst healthcare professionals, the onus will remain on the patient to be their own case managers and to follow up. The 6-month impact data really hit hard, and the medical manager, the dietitian, the speech therapist, and the audio committed to twice monthly home visit days with a physio or OT and a parent facilitator to assist. Unfortunately, besides the dietitian, the other health professionals consistently did not use the data to plan a follow-up, and the onus remained on the rehab team leader to organize the outreach days time and time again. And without the rehab team leader seriously driving and organizing each outreach day, it was unlikely to happen. You win some and you lose some. But what it did do was make the whole multidisciplinary health team a whole lot more disability friendly. Suddenly, it was a lot easier to galvanize the whole team to see an unbooked outpatient on the same day. Doctors started seeing children with CP as kids first. Referrals improved. There was a fundamental shift in attitude towards saving the patients the cost of travel and coordinating care better. Outreach team leaders relied on rehab for transport, and we balanced the cases between rehab patients and other home-based care patients that they wanted to see. Suddenly, rehab's patients became everyone's patients. So the OTLs created a nappy list per clinic and got them delivered at homestead level. We could refer downwards from wards directly to the outreach team leaders instead of waiting a month to speak with the community health workers at their meeting. So I don't have a final answer as to how to ensure routine, coordinated and comprehensive care at a cost that's affordable to quintile 1 families. And the strategy will be so contextual. That sounds fun. The strategy will have to be so contextual, but it is something that needs some serious attention. So this all sounds fantastic, but where is our rehab team now? And where's this program now? So the thing is, our systems are fragile. Maternity leave doesn't trigger a locum position. So you're out without that therapist for months on end. We're a generalist practice that has to see everything and anything across wards, outpatients, clinic, and home visits. A simple policy change, such as preventing community service therapists from driving state vehicles, can literally decimate outreach services overnight. Wheelchair seating services are highly specialized. They take around 3 to 4 hours per client. If this person goes on extended leave, reviews will take a backseat, especially considering that there are 140 intermediate seating clients and 92 advanced seating clients on the list. This is also against a backdrop of an ever-growing caseload, including clients from outside of our health catchment area, which makes track and trace incredibly difficult. So as much as no one wants to show their failures, I think this is where the greatest learning can happen. But without active monitoring, even this slump would have gone unnoticed and unaddressed. So I'm thankful for our data, I'm thankful for our system, and I'm thankful for our team. But most of all, thank goodness for parent facilitators who are literally adding 4 times the number of hours as we are as therapists per child per annum, whilst we try and address our shortcomings. No one has been lost to follow-up, maternity leave is over, and the wheelchair seating champion is back. Let's hope things go back up. So let's go back to the original story about Baby X. Baby X's posture support buggy arrived, and we tried calling the contact numbers several times to no avail. We decided to drive out the 90 kilometers and trace the homestead based on the directions on the buggy prescription form. Finding the homestead abandoned, we tried calling the 2 numbers again. One went to voicemail, the other one was answered by an aggressive male voice.
Hello.
Hi, sorry.
Okay.
Yeah. And the aggressive male voice claimed not to know these people. We returned again the next week. The house was still abandoned. We hung around and tried to knock at the neighbor's house. Although it was clear that there was somebody home at the neighbor's house, it took the lady a long time to come out and greet us. She'd not let us into her yard. When we asked the mother and the baby's ex's whereabouts, she bluntly told us that they had moved. Eventually, she dropped her voice and said, if we drove to a high school 20 kilometers away and asked around, we might find them. So we drove there. No one knew them. It took us another 2 hours to find their house. Baby X's mom had been in a stable relationship and had 4 children with the same father. One day she woke up to find he had paid lobola for that neighbor. He kicked them out. The mother had no ID papers, and the 4 children, including baby X, had no birth certificates. Whilst the school at the original homestead had allowed the 3 older kids to attend school without papers, the new area did not. Baby X's mother, to whom she had moved back to, also had no papers and earned a few rands ploughing for other people, even though she was around 80 years old. Although baby X was in remarkably good shape, thankfully he did not have a high EDAX score. Any trip to the clinic was now a 10-kilometer walk each way, as there was no money for transport. Although we issued him a brand new buggy and customized it for him, this is now really the least of the family's concerns at this point. Thankfully, by finding them, they're now linked to the municipal councillor and the full multidisciplinary hospital team. The councillor has been supportive of the mum in trying to apply for an ID. They also receive food parcels from a faith-based organisation, and the parent facilitator has continued to visit the mother regularly to provide psychosocial support and monitor the situation. All of this takes time and multiple follow-ups, but without it, rehab as we know it cannot really start. 2 years later, the 3 older children are back at school, and baby X is standing in his APT standing frame, continues to get routine home visits from the rehab team and the parent facilitator, and enjoys going to the fields with his mother in his posture support buggy daily. Whilst the current recommendations around rehab dose per age group are indeed laudable, as a well-staffed district hospital rehab team, we would need to add 2 additional therapists solely dedicated to block therapy weeks in order to meet these recommendations. This is running block weeks back to back for 46 weeks of the year and assumes that every single patient and their main caregiver can attend a week of block therapy, which we know is not the case. And in the end, we have to look beyond a medical model and ask what our broader program objectives are and how much we're going to need to rely on other departments outside of health to step up in order to make all of this effort worthwhile. There will not be a single solution or a single silver bullet, but if we can start with collecting decent data and recognizing how our own systems perpetuate poverty and inequality, we can start having these conversations. Thank you.
Thank you. Thanks, Marika. Wow. What an overview and what incredible work you've shared. Thank you for all the preparation and pulling that together. And what a demonstration of a kind of learning health system approach, which is one of the webinars we've had previously. Data-informed decision-making. I think we must open up for some questions so let's see who anyone wants to ask any questions, have any clarifications, or make comments or share from their experience. And Marika, again, I've got my camera on. Do you think yours will hold or maybe not?
Yeah, should do. Let's try.
Okay, great. Let's try. And then Million, please, you go ahead first and then Sharon. Thank you so much. Million, you are still on mute. While we are waiting, and Million, so I just encourage you to check your mic because we'd love to hear your question. I
think it's coming right now. Okay.
It's coming through now. Excellent.
Great. Thank you, Tamara. Thank you, Marika, for such a very incredible and touchy, very detailed presentation. I really appreciate. And this is also in my heart. Almost 30 years ago, I have done a similar job where we had this group of nurses and life skill training, community health workers. We went home to identify children with cerebral palsy, and we did quite a lot of life skill training, and especially when we start at a younger age, I think the improvement is very rewarding, and which is very important. What is most supporting us is we brought NGOs into our program to support us in terms of training the community healthy workers. Because the community healthy workers, once we train them, we can send them home to home to identify the children with cerebral palsy, and they can do life training for those at a milder to moderate level. The severe one, they can actually refer to the physiotherapist, specialist, and also we have worked with the Department of Health, where we can get a free services in terms of the treatment and the management. I think that works very well for us, but in your case, I can see home-to-home visit is very challenging, because it's not feasible with the number of staff you have to go to home-to-home visit and identify and provide those very important services. Have you tried to have some NGOs to support on those areas? Because now, if you are not there, I can see, I don't think the sustainability of this project in future, what's going to happen? Is there Department of Health coming into board to assist on that aspect?
So, I mean, we work very closely with our community health workers. We meet them once a month for a general meeting. And then when we go out into the community, we stop at the clinic, we pick up the outreach team leader and the relevant community health worker for that patient. And we put them in the car and we go to the homestead together. So in that way, that link has been made, and they sit through the session, they assist with the session as well. So in that sense, the community health workers are very invaluable to us. They do all of our track and trace. They do the homestead checkups to see how it's going, etc., and they also flag issues for us. The parent facilitators are under the DPO. So we have 4 parent facilitators. Those are parents of children with cerebral palsy that have attended a formal training course. The reason I really like working with them is that they have the actual lived experience of having a child with CP. And so they are more believable. If you've never spent 24 hours caring for a child with CP, you don't know what it's like. So yes, a lot of the stuff can be done by community health workers, but we cannot negate the lived experience of people who have walked in your shoes. I'm hoping that we can look at expanding the parent facilitator program or just capacitating it more. And they definitely do provide a bulk of the home visit services. However, for seating reviews, I'm not going to expect them to do that. All of the children are either intermediate or advanced seating cases, and not even a junior therapist is going to cope with that. So the seating is a quick win. If done properly, it is part of your 24-hour postural management strategy. And it assists with so many other facets of daily life, as well as postural management. So in that sense, we're going to have to stick with a therapist going out to home visits. But for the additional stuff, yes, I'm definitely into task shifting. I hope that answers the question.
Thank you.
Thanks for sharing your experience also, Million. Sharon, thanks. Welcome.
Thank you, and thanks for a fabulous presentation. I wanted to ask 2 questions and then just make a comment. I'll start with a comment, and that is, what you're doing is absolutely fantastic. And I'm sure you'd be the first one to admit it's not rocket science. It's how to run a proper service. And what I found interesting is that we're in 2026. You know, in 1994, when the Cuban doctors first came here, they tried to reorientate primary care so that everybody, the clinic was closed for 1 day a week or 1 day a month, I can't remember, and everyone from the clinic went out into the community. Obviously, that's easier when the communities are close and they're clustered and so on, more difficult when they're widespread. But, you know, you could work out a plan, this place, this day. And it's sort of sad that we are still learning the same lessons so many years later. And all kudos to you for plugging away at it. So just really my hat off to you. But really, I fear for us. What is wrong with us that we can't learn? My question is the following, two of them. The parent facilitators, are they paid? And if so, from where? And I suppose I'm thinking about this in terms of costing the service and looking at sustainability, and hopefully some master students could come out and do that costing work, and I will connect you with those from my institution who I think should be doing it. And as you're in Joburg, we might do it tomorrow. That's the one question. And the second question is, you keep talking about data. Can you tell me, I'm thinking you're doing things like have someone returned or not, but can you say what data it is that you started collecting, or that people, that you think is essential and that people have difficulty using? What are those data? Thank you.
Okay. So I totally agree with that. We are just almost reinventing the wheel. I was lucky enough to graduate and hit the tail end of the amazingness of primary healthcare just before it crashed, burnt, and did a 180. So I learned from the best. And it is back to basics. If you read minutes from like 25 years ago, you just want to cry because you're like, this is amazing. This is what we need to do. But we were saying that 25 years ago. So yeah, the parent facilitators are trained by Malamalele onwards. That's an NGO. They belong to their own organization. So it was started by a man with a spinal cord injury who trained up as a peer supporter, and he started the NPO. And then the parent facilitators were brought into the NPO as well. The NPO is funded by the Rachel Swart Fund, which is another NGO which is Cape Town based. So they get a stipend for number of hours worked is number of hours paid, and that is handled between the Rachel Swart Fund and their DPO. The data that we collect, so we base it, it's built around the patient health profile itself. So you enter the first bit of data once. You can edit it if the patient moves clinics or moves areas or changes cell phone numbers or whatever. And then we have additional tabs, which would be the specialized programs that we want to monitor. So when I say it's a high-risk service, it would be if the patient is lost to follow-up, the result is going to be disastrous. So this would be things like cerebral palsy, wheelchair seatings, home-based care in general, mental health care. Audios have their early hearing detection and intervention, the high-risk baby program. So if you are lost to follow up for whatever the reason is, and you don't come back into the service, chances are, if I don't follow you up, by the time you do get back into the service, it's going to be pressure sores, contractures, deafness, delays, like serious stuff. So those are the programs we want to monitor. You know what, if you have low back pain and you don't come back for your follow-up appointment, onus is on you. I can't monitor everything. So those services that are high risk are typically also the ones where we need to move out into the community because there is an access problem or a retention and care problem. So those services then have their own program dashboards. The data that is pulled to generate the data for the dashboards is pulled from the patient record itself. So that's like the patient's clinic, area, name, what programs they're in, Yeah, that would be the basic data. And then the program-specific data you would enter additionally. When you enter them into that program, you're entering specific data into it as well. The stuff that comes up, so our teams are organized into a physio and an OT per residential clinic. And all the feeder mobile points that belong to that is belonging to that OT and physio. That is your clinic for the year. And you are responsible for all the home-based care, all the seating, all the CP, all the everything else under that clinic. And if you can't do it because you don't have the skills, the onus is on you to be case manager to bring in somebody from our team to come out and to address it. So what pops up on your clinic dashboard is the proportion of home-based care visits up to date, the proportion of intermediate seating reviews up to date, and then the ones that are overdue, the list is generated with the phone numbers and everything. Now you have to go out and do your overdue stuff. Then the indicators for the program would be things like what I've shown you on the slideshow, which would be like how many kids are in the program for CP, what the wheelchair coverage rate is, what the wheelchair review rate is, what the twice annual wheelchair review rate is. You can generate more and more indicators using just the general information that you collect, but you don't want to overload the system because healthcare workers typically aren't using this data as it stands. There's no sense adding more. Rather keep it with minimal, and then as people start to see the use in it, then you add more, then you start discussing, okay, how much additional time would you like to spend entering more data to get more data back? So yeah, it's an ever-evolving system.
Thanks, Sharon. Thanks, Marika. And Amilka, you had your hand up, but I'm maybe just checking if you wanted to add.
Sure. Yeah, I do have a question and one comment. First, thanks, Marika, for the excellent storytelling. It's not grateful to have joined this presentation. My question is around the transport. You know, transport's been an issue to get to as a cost to get to healthcare facilities. What are some of the kind of funding options that you guys may have used in that area of the country to assist with that? So is it paying the patient to transport? Is it providing transport? Is it building trains in the area? That kind of thing. Because I mean, going forward, we have it. Trains and trams.
No, literally, it's my rehab team and 2 outreach cars. So it's tough to get an outreach car, and it's important that when you complain, you use the same email train for many, many, many years until it reaches the right person who actually does something about it, and then all of a sudden, you get a car. So we were lucky. under COVID, we slid the need for the second, because we knew we needed a second car, because if we only have one car, we do the primary healthcare clinic first, and then depending on how busy it is, when it's finished, then we go out into the community there, and then we start the home visits, which means you get back very late. So we weren't getting to all the home visits, so we knew we needed a second car. So under COVID, then they wanted to do all of the screening, you know, and the awareness and the screening. We said, but we know where all of these disability households are, and you guys are never going to get to it. And, you know, some people need special strategies. So can we be the disability COVID outreach team? They said, yes. We said, okay, thank you. Next car. Yeah, never waste a good crisis.
Definitely, sure.
Yeah, but it is a massive issue. I would love planned patient transport to be wheelchair accessible. It is a constant gripe of mine. Between district hospital and tertiary level, because I can't get my clients to tertiary services easily. Trauma trumps disability. I get it, but it's not fair. And between clinics and hospital, that would really, really help. But we don't have any planned patient transport. between clinics and hospital, and between hospital and tertiary, if you use a walking frame or a wheelchair, you're not getting on.
So costing out, decentralizing, and there's so many economic models that tell us if we invested more in community care, that we'd actually be doing ourselves a service and creating more affordable health services altogether. But for another topic, I'm going to ask everyone here, if you have any topics that you're keen to hear about, you can add them into the chat, or if you have something to share, you are also welcome. I want to say, Marika, Lloyd wrote in the chat. Lloyd, like many of us, is a fan of your work from Plus Lisa. And also lastly, and I think it's a good place to wrap up, is Yashna was asking whether you've published, whether you've written this up at all, because it's incredibly interesting, it's incredibly important, and she would like to disseminate it.
Please, can you help kick me up the proverbial?
Okay.
And make me do
Yeah,
it.
so that was your little gentle nudge, but I mean, maybe if there's any kicking up needed and any support needed, I think I think this is vital work. I think there's a lot. I mean, Sharon mentioned it's not rocket science, it's what we should be doing. And now it's fancily called learning health systems, but it's just data-informed care. And it was a brilliant presentation, so thoughtful, thought-provoking, and so human-centered. And yeah, I think since it's always this funny space, but I think maybe we can do a round of applause. We'll use the emoji things, but just to acknowledge and recognize the incredible work you've done. And yeah, absolutely. So yeah, any help you need with writing up and things, we'll give you a writing retreat in our unit if you want to come hang out.
Yay, Cape Town.
Yay. Come to Cape Town. And yeah, again, everyone, it's a really great space where we can hear these stories and share. I'm sure many of you are doing incredible work. Doesn't matter if you're just starting on your public health journey, or have been around in health systems for decades. Please share in the chat or via email with Ari or myself or Kim, if there's something or someone that should be celebrated and have the opportunity to share. So I'm not sure what's lined up for March. I have a feeling we've been a little bit draggy on that, so we'll let everyone know. But again, Marika, thank you so much for your time. So much appreciated. I'm glad we finally got there. Yeah.
Thank you for inviting me.
Thanks, everyone. Take care. Have a lovely afternoon forward. Bye, everyone.
Thank you. Cheers.
Thanks,
Bye.
Marika, again.
Thank you. Bye.